We described the pharmacokinetic and pharmacodynamic properties of anti-infective agents used for treatment of STIs and explained the pathophysiology and clinical presentation of STIs, and also interpreted diagnostic laboratory findings to confirm the presence of some sexually transmitted infections. Now, given a patient case, recommend guideline-concordant treatment for genital herpes, gonorrhea, chlamydia, and syphilis. Let's take a look at the management of genital herpes. The goal of treatment for genital herpes is to treat or prevent symptomatic genital herpes recurrences and improve quality of life and suppress the virus to prevent transmission to sexual partners. Now, antiviral drugs neither eradicate latent virus nor affect the risk, frequency, or severity of recurrences after drug is discontinued. It just helps us manage the symptoms as well as reduce the transmission. Topical therapy with antiviral drugs have minimal efficacy, and therefore they are discouraged for genital herpes specifically. Now, all patients with first episodes of genital herpes should receive antiviral therapy regardless of severity, and these are systemic antivirals, so either oral or IV. And IV specifically should be provided, and that's IV acyclovir for a severe HSV disease or complications that necessitate hospitalization. For example, people with disseminated infection, pneumonitis, or hepatitis, or if someone has CNS complications such as meningitis or encephalitis due to HSV. Now, here are the treatment recommendations from the CDC guidelines from 2021 for treatment of first clinical episodes of genital herpes, and it doesn't matter if it's HSV1 or HSV2. So essentially any of the three oral antiviral regimens are recommended. So acyclovir for 7 to 10 days, valacyclovir for 7 to 10 days, or famciclovir for 7 to 10 days. Now you can see that acyclovir and famciclovir are dosed 3 times a day, so it makes sense to use valacyclovir, which is dosed twice a day, to improve adherence for patients, but any of these are appropriate for treatment. Now, the treatment is recommended for 7 to 10 days, but use clinical judgment, so if some patients may need more than 10 days if healing is incomplete. Now, treatment of recurrence is recommendation specifically for HSV2, because remember that HSV1 is less likely to have recurrence, and essentially there aren't there is insufficient evidence to make recommendations for HSV1 recurrence. But should you be in a situation where there is HSV1 recurrence, you can probably extrapolate from HSV2 recommendations. But for the most part, the recommendations are for HSV2 because that's where the evidence is. So when it comes to recurrence, there are 2 strategies. One is suppressive therapy, which you essentially continue to give antiviral agents to patients for long time. Or you can have episodic therapy. So episodic therapy, you essentially wait until they have a recurrence, and once the recurrence happens, immediately you trigger the episodic therapy. And we essentially use the same agent, so acyclovir, valacyclovir, and famciclovir for suppressive therapy specifically. So the dosing is a bit different. It's based on the doses that have been studied for this purpose. And you can see that valacyclovir has been studied as 1 gram once a day. So that probably makes it the easier option for patients who essentially have to take this for a very, very long time, if not lifetime. So, once a day. And episodic would be essentially once the patient has developed, you initiate these, and, acyclovir for 2 days is an option, or valacyclovir for 3 to 5 days, or famciclovir, 2 times of 1 gram 2 times a day for a single day. That probably is the easiest one for episodic, to make it easier. But any of these agents are recommended for these purposes. Now, as far as the efficacy, essentially the suppressive therapy It's probably the most effective. It reduces frequency of genital herpes recurrences by 70 to 80% among patients who have frequent recurrences. Let's switch gear to management of chlamydia. So the preferred regimen for chlamydial infection is doxycycline, 100 milligram 2 times a day for 7 days. So this is a standard 7-day regimen. Alternatively, if someone cannot tolerate or access doxycycline, azithromycin 1 gram as a single dose or levofloxacin 500 milligram daily for 7 days are recommended from the CDC. Now with azithromycin, you might ask, if this is a single dose, why not use azithromycin as preferred? And that's because there has been increased microbiologic treatment failure, with azithromycin compared to doxycycline. So for that reason, doxycycline is more effective and is recommended first line over azithromycin. And that's including for rectal chlamydia and oropharyngeal chlamydia, doxycycline is more effective than azithromycin. Now, one thing with doxycycline, because it's dosed twice a day, there is a formulation available as delayed release. So it would be a single 200 milligram tablet, which requires once daily dosing for 7 days. It is more expensive, but it does have lower frequency of GI side effects and it improves adherence. So that's an option. Now, men and women who have been treated for chlamydia should be retested approximately 3 months after treatment, regardless of whether they believe their sex partners were treated. And that's to make sure that their infection has been eradicated. For gonorrhea, for the preferred regimen for uncomplicated gonococcal infection of cervix, urethra, rectum, or pharynx, is essentially ceftriaxone 500 milligram intramuscular injection as a single dose. And if someone weighs more than 150 kilos, they would require 1 gram of ceftriaxone. So that's pretty much the standard of care right now. Now, if somebody for some reason cannot tolerate ceftriaxone, alternative regimen includes gentamicin plus azithromycin as a single dose. And if they needed an oral option, cefixime is an option, which is an oral cephalosporin that they can use as a single dose. Now, these alternative agents are not for pharyngeal gonorrhea. Essentially, these are not as effective for pharyngeal gonorrhea. So in that case, an ID specialist should be consulted to see what options are available, but the guidelines don't make any recommendation. Now, because people who have gonorrhea, the symptoms overlap with chlamydia. If chlamydia has not been excluded and somebody is taking either ceftriaxone monotherapy or cefixime monotherapy, because cephalosporins don't have activity against atypical agents, it is recommended to add doxycycline on top of the ceftriaxone to cover for potential chlamydia infection. And once the culture results are back and it's confirmed that the patient does not have chlamydia, this can be discontinued. Now, for gonococcal conjunctivitis, again, ceftriaxone is recommended, but at a higher dose of 1 gram. And any person with pharyngeal gonorrhea should return 7 to 14 days after initial treatment for a test of cure by using either a culture or nucleic acid amplification test. And all positive cultures for test of cure should undergo antimicrobial susceptibility testing because of the increased rate of resistance in gonorrhea. And men and women who have been treated for gonorrhea should be retested 3 months after treatment, similar to chlamydia, to make sure that their infection has been eradicated. Now, for syphilis, the treatment is the same for primary and secondary syphilis, and even for early latent syphilis. So early latent is someone who has been having latent syphilis for less than a year. So essentially, penicillin is drug of choice, specifically intramuscular injection. So it's a single dose because remember that this gives a large dose that's slowly released over a period of time. So that's pretty much the standard of care. For people with severe penicillin allergy, doxycycline, ceftriaxone, and azithromycin have been studied, but again, by far, penicillins have been studied the most. So even if someone has allergy, they may be able to get desensitized to penicillin and receive penicillin for that purpose. Now, for latent syphilis, so this is essentially latent for more than a year, or if the duration is unknown, and also for tertiary syphilis with normal CSF, so essentially tertiary syphilis but not neurosyphilis, so this excludes neurosyphilis. The preferred agent is again intramuscular penicillin, but not just a single dose. So this should be a 3-dose series at 1 week interval. So they get 1 dose today, the second dose 1 week from now, and the third dose 2 weeks from now. And alternative is doxycycline for 28 days. So the duration of treatment would be for 4 weeks instead of 2 weeks for latent syphilis. For neurosyphilis, intramuscular penicillin is not appropriate because it will not lead to adequate concentrations in the CSF. So preferred is IV infusion of aqueous crystalline penicillin at large doses of 18 to 24 million units per day. And that can be done either as administration of 3 to 4 million units every 4 hours, or as a continuous infusion, and duration of therapy is 10 to 14 days. Now, alternative recommendation used to be procaine penicillin, but since this has been discontinued, we don't have to worry about this right now.